So the title is in front of you. We are dealing with left main, which has multiple distal vessels, and this is the left main trifurcation. The incidence is about 10 to 15% in the literature. And what we need to do is, where is the pointer? I mean, you're generally going to put a stent from left main to LAD and then to take care of the side branches as you go in. This is generally the thinking. Then also you need to match the diameters. I mean, left main diameter generally matches well with the LAD diameter, but there are some cases where you will find that the circumflex is a dominant vessel and the left main probably is matching more or matching better with circumflex compared to LAD. And then you have this thought whether the stent should go from left main to circumflex and LAD should be treated as a side branch. So in this case, this is actually a book picture, but there is a trifurcation at a distal end. The first stent is going from left main to LAD, and these two are attached as T-stent strategy. Generally, I would feel that one should be very liberal in stent overlap in the left main distality. This is a case, 78-year-old, and he had a high bleeding risk. This was one of our concern. And you have LAD, which is showing a disease, the OM1, which actually has two branches, also showing an osseous disease. And then you have a circumflex, which is a dominant circulation, you can see here. So in this case, whether circumflex needs a stent, this is an important issue. Stress test was strongly positive. So just at the beginning, we do FFR towards circumflex, and you can find the FFR is grossly abnormal, which means that when we address this vessel, we need to do something to LAD, something to OM1, and these two branches, and then also the circumflex, which is showing a FFR, which is clearly abnormal. So we we had a thought of doing a decay crush on LAD. Then we thought we'll put a stent from left main to circumflex, which is a dominant circulation, and then try to address through that the OM1, or do LAD, OM1, then put a stent from left main to circumflex. So here we were trying to do a decay crush, and you can see the balloon went a little bit ahead compared to the origin of the LAD, and it hurt the osseum of the OM1. You can see immediately after balloon dilatation, there is no flow in the OM at all. So this is an acute occlusion right in the beginning. I think something which you and I would worry strongly because we had to sort of do some quick thinking, get a wire in. We got cross 100 into the OM1. You can see it here, and switched our strategy. We thought we had done a decay crush to LAD. We'll do a mini crush, and then we will put a stent towards circumflex. Mind you, it is a left dominant circulation. So here the stent comes in, and the stent is ready from left main to dominant looking circumflex. We deploy the stent in the OM, bring the same balloon back and go high pressure in case if you're not able to re-enter this vessel with wire and balloon, and then deployed the left main to circumflex stent. As you can see here, good flows. All three vessels are flowing well. So at this stage, you do pot up to LAD, wire the LAD, then do pot up to the OM1, wire the OM1. So you see on left side, all the three wires are in again. So this was the wire on which the left main stent is going, the circumflex, and then LAD and OM1 wires are brought in. So we do a kiss between the branches. It's going to be a disaster. These are the, I don't know why there is a black thing here, but you can see this. This is how the lesion was, and this is how we ended, and this is a stent boost which is showing the stent lie. This is a similar case. This is not the same case, but again an important lesion at the mouth of the LAD. The OM1 is small and probably has a lesion at the mouth, and this is the circumflex, which is again a big vessel. So here the FFR was negative, 0.93. So we decided that we need not do anything to the circumflex. So the first stent went from left main to LAD, do a pot, and then you bring in another stent towards the ramus, and you can see here it has a TN protrusion with the left main LAD stent, and you get this kind of result. So these are the two cases which we saw. One had a positive FFR, one has a negative FFR. So the positive FFR got 3 stents, while negative FFR was done with 2 stents. You can see here 3 stents and 2 stents. So whenever a patient has CT angio, I think we all must learn to pay some attention to the CT angio. This is actually a CTA and FFR to pick up vulnerable plaque. The lesion may not look critical, but if the plaque is vulnerable, I think you need to respect and give some important decisions. So this is a critical LAD lesion. This was stented, but you see in addition distality of left main, proximal portion of the OM, and proximal portion of the LAD, orchial LAD, question mark. So here we have done FFR to circumflex, which was abnormal, then FFR to LAD, which was also abnormal, and that means we have problems at the distal end of the left main, or the proximal LAD and proximal LCX. So after putting in a stent at the criticality or in the LAD, we have to put 2 more stents. So you could choose TN protrusion after you put in left main to LAD, or you do a culotte. So we preferred culottes because in left main there is no role for not covering an area with a metal. So this takes a little extra steps, but I think, so the first stent was in proximal LAD. Next one was from left main to join the LAD stent, and then we are getting ready to deliver the stent from left main to OM1. And this is the final result. You can see good flows in all the branches. And this is how the stent lies. The first stent, the second stent coming back to left main, and then a culotte where this stent is coming back also into left main. You must do a kiss when you do this kind of multi-layered stenting. So this is in short how we did it. 1 stent, second stent left main to LAD, do a pot, wire into circumflex, stent into circumflex, a good length of stent in the left main, and final result. There are, however, many variations. Like in this case, you have left main giving rise to almost 4 branches. And you have to choose your technique. I would feel that in this case, the stent goes from left main to LAD, and then you attach a second stent as TN protrusion. The first branch, the diagonal branch, was kept as provisional, and we did not stent it, and also the circumflex we did not stent. In contrast, this particular case has a critical lesion at the mouth of the middle branch. Circumflex is small, LAD is also reasonably small, but this vessel, you can see this is how we stented, going from left main to the big vessel, and LAD was stented with a TN protrusion, and this is how you see the middle branch is actually this going all the way to apex. So whichever is the big branch, I would feel the left main continuity should be towards that branch. This is another case, highly unstable patient, and so in these cases we don't like to lose flow in the side branch even for a short while. So the first stent was placed from left main towards circumflex. This is again a dominant left. Second one was placed at the OM1 as tap, and third one was placed at the LAD again as tap, and this is the final result. So when patient is hot, recurrent problems, I think losing the side branch flow even for a small while could be difficult. This was another case where we did a rotablator to left main to LAD, and there were two important side branches. Patient was in borderline pressure, and we did a TN protrusion to these two important branches. And I'm sorry this is not running, but you can trust me, this is the lie of the stent, and there were good flows. So this was another case, and this was done in a peripheral hospital. We got the patient about 14 months after the stent was done. He had symptoms, effort symptoms, about 6 months after the stent. Now the operator has put 3 into 18 line stents. So left main is stented with 3/0 going towards LAD. Probably he has gone with the size of the proximal LAD. Even then, I think this should have been a 4/0 or at least 3/5, and you stretch the back part with 4/0, 5/0. So we put a stent from left main osseum towards circumflex after good bed preparation with a cutting balloon, and this is how the stent is dilated. We actually had assessed the old stent. In this color, the old stent is very faint. You can see a yellow color if you can. It was assessed with IVUS and it was underexpanded. So we put another stent towards LAD. So a lot of work, we call it delayed second culottes, because the first culotte was between the left main LCA stent with the existent old stent, and the second one was the new stent from left main to LAD. Now this was a decay crush to left main distality. So you have two stents and result looks quite good, but within 6 months this patient comes back. We have taken all the care. You can see here, it's written here, we had done a POT, you had done a non-compliant balloon, high pressure. However, yet this patient comes with a critical ostial circumflex stenosis. It was a big size circulation and patient was getting heavy angina, active man, and we did a IVUS, and the stent looks quite well expanded. So in this case, after doing IVUS, we just put a drug balloon. We used a cutting balloon. Then we expanded the stent and put a only a DEB and did not put another stent. And this is the final result. It's about a year and a half, patient is doing quite well. So this is another case which was done outside, a stent going from left main to LAD, and a big size circumflex circulation, which was treated as a side branch. And you can see critical osteial stenosis. This was about 10 months after the procedure. And in this case, we actually put, and this is a big dominant circulation. So we did a culotte with the old stent and put a stent from left main towards circumflex. So we use cutting balloon. You can see a kiss, a final part, and this is the final result. The left main to circumflex, and this is the old stent. This is another case. I'll just show this as a last case. This was done in another hospital, I think it's about 2 months back. So this is how the operator left. He put a stent from left main to LAD, and I find some narrowing at the mouth of the circumflex, which is again a dominant big circulation. For some reason, the operator didn't do anything to the circumflex. And as you would expect, within 2 months, patient came with heavy angina. And this is a repeat angiogram done in the same center, where you'd see no flow from left main to circumflex. Circumflex is filling up backwards through the LAD. And it's again a very important circumflex circulation. So this is where we use this special catheter called Sasuke. Sasuke has 2 holes. One is at the tip, and this tip hole takes a wire to the OM branch, and the side hole allows you to bring in a wire towards the circumflex, which is the dominant vessel. So this is how the wiring was done, and stent was placed as TN protrusion. I think I must show you this case. So this was a critical left main distality.
I think we need to wrap up.